In this chapter, we'll be discussing about spinal injuries. So fractures and dislocations of the spine are serious injuries because they may be associated with damage to the spinal cord or the cauda equina. Thoracolumbar segment is most commonly injured, followed by the cervical spine. So if the cervical spine is injured and if there is a neurological deficit, it will be quadriplegia. And if the thoracolumbar segment is injured, there could be paraplegia. Okay. So moving on to the relevant anatomy. So the vertebral column consists of 33 vertebrae. So 7 cervical, 12 dorsal or thoracic, 5 lumbar, 5 sacral and 4 coccygeal. They are joined by ligaments and muscles. So each vertebra, you have an anterior body and a posterior neural arch. So each vertebral body, it has a central part of cancellous bone and a peripheral cortex of compact bone. Okay, so the margins of the upper and the lower, so the upper and the lower margins of the vertebral body are thickened to form the vertebral rings. Okay, the neural arch here, it is formed by the pedicle, the articular facets, the lamina and the spinous processes. Okay, so between any two vertebrae is a strong cushion, the intervertebral disc. So basically it consists of two portions, a central nucleus pulposus and a peripheral annulus fibrosus. The nucleus pulposus is a remnant of the notochord and it is made up of mucogelatinous material, and the annulus fibrosus is made up of fibrous tissue and surrounds the nucleus pulposus. So moving on to the articulation, the entire vertebral column has similar articulation except the atlantoaxial joint. So the vertebral bodies are primarily joined by the intervertebral discs. So anteriorly, the vertebral bodies are connected to one another by a long strap-like anterior longitudinal ligament, and posteriorly by a similar posterior longitudinal ligament. So the neural arches of the adjacent vertebrae, they are connected by facet joints. Okay. So these are synovial joints with a thick capsule. The adjacent laminae are joined together by a thick elastic ligament, the ligamentum flavum. Okay. So the adjacent laminae, the fibrous laminae. Okay. So the facet joints, the laminae, they are connected by the ligamentum flavum. Then you have interspinous ligaments which connect the adjacent spinous processes. Okay. And you also have the supraspinous ligament, so which connects the tip of the adjacent spinous processes. Then you also have intertransverse ligaments which connect the adjacent transverse processes. Okay. So and also you have all of these ligaments, right? So these ligaments, they're often termed as a posterior ligament complex. So you have the posterior longitudinal ligament, you have the interspinous and supraspinous ligaments, and you also have the intertransverse ligaments. All right, so ligamentum flavum as well. So all this. So the direction and size of the articular facets is different in different parts of the spine, and this is important because, see, in the cervical spine they are more horizontally placed. So that is why they commonly can dislocate, whereas in the lumbar spine they are more vertically placed. So pure dislocation without any associated fracture, it does not occur in the lumbar spine. Okay, so moving on to the biomechanics of injury. So the mode of injury, it could be most commonly a fall from the height, such as a fall from a tree. It is the most common mode of sustaining a spinal injury in developing countries. In developed countries, RTAs account for the maximum number, so road traffic accidents. But in developing countries, it is fall from a height. Next, stable and unstable injuries. So it is crucial to assess the stability of an injured spine for purposes of treatment. So a stable injury is one where further displacement between the two vertebral bodies cannot occur because of the intact mechanical linkages. Further displacement cannot occur. That is stable injury. So an unstable injury is one where further displacement can occur because of serious disruption of one of the structures responsible for stability. Often it is difficult to decide with surety whether the spine is stable, but in all such cases, it is better to treat them as unstable injuries. Then you have something called the 3-column concept. So basically the spine can be divided into 3 columns, the anterior column, the middle column and the posterior column. This is the anterior column and this is the posterior column. So basically the anterior column, it consists of the anterior longitudinal ligament, as you can see here. So the anterior longitudinal ligament along with the anterior part of the annulus fibrosus and the anterior half of the vertebral body. Okay, so the anterior longitudinal ligament, the anterior part of the annulus fibrosus and the anterior half of the vertebral body. So the middle portion is comprised by the posterior half of the vertebral body, the posterior longitudinal ligament, and the posterior part of the annulus fibrosus. Okay. Then the posterior column, it consists of the posterior bony arches along with the posterior ligament complex. Okay, so you have the anterior, middle and posterior column. So that is the 3-column concept. So in different spinal injuries, the integrity of one or more of these columns may be disrupted, resulting in threat to the stability of the spine. So when only one column is disrupted, such as a wedge compression fracture of the vertebra, the spine is stable. When 2 columns are disrupted, the spine is considered unstable. When all 3 columns are disrupted, the spine is always unstable. Okay, so the spinal injuries are best classified on the basis of mechanism of injury into the following types. So first, you have something called the flexion injury. It is the most common spinal injury. So see here, the spine is totally being flexed because the person is falling from a height on the buttocks or on the feet as well. So your spine, when you're falling from a height, your spine is curved. Okay, it is flexed. So flexion injury can occur, and also when there is a heavy blow across the shoulder by a heavy object. So if you are hitting like this and your shoulder kind of bends, your spine is also bending and you are getting a flexion injury there. Okay, so what happens is a flexion force can result in a sprain of the ligaments and the muscles of the back of the neck. Here you can see the neck is excessively curved. The cervical spine, it is getting curved, it is flexed. And there can also be a compression fracture of the vertebral body C5 to C7, okay, especially in the lower neck. There can also be dislocation of one vertebra, so C5 over C6. C5 can dislocate over C6, C5 to C7, there can be a compression fracture. Okay, in the dorsal lumbar spine, this force can result in wedge compression of the L1 vertebra most commonly, followed by L2 and D12 as well. Okay, then it is a stable injury if compression of the vertebra is less than 50% of its posterior height. So if this is X and if this anterior height is X by 2 or more, so that means it is unstable. But if the height is less than 50, if it is greater than 50% of the posterior height, it is, you can think of it as stable. Then after flexion injury, you have flexion rotation injury. So it is the worst type of spinal injury because it leaves a highly unstable spine associated with a high incidence of neurological damage. For examples, see on one shoulder, if there is a on both shoulders, if there's a blow, you can have a flexion injury. But on one shoulder, you can have a flexion rotation injury. And you can also have a blow or a fall on the posterior lateral aspect of the head. So what happens is, this force can result in dislocation of the facet joints on one or both the sides, or the fracture dislocation of the cervical vertebra. So in dorsal lumbar spine, this force can result in a fracture dislocation of the spine. So you can basically have a fracture dislocation because it is a very unstable injury. So here one vertebra is twisted off in front of the one below it. Okay, so while dislocating, it takes a slice of the lower vertebra with it. Okay, so there is also extensive damage to the neural arch and the posterior ligament complex. Then you can have a vertebral compression injury. It is a common spinal injury. So when you fall on top, erect on your head, so what happens is basically the vertebra can get compressed. So this force results in a burst fracture. The vertebral body is crushed throughout its vertical dimensions, as you can see here. Okay, so this can also exert some pressure onto the cord because a piece of bone or disc may get displaced into the spinal canal. So in the dorsal lumbar spine, this force results in a fracture similar to that in the cervical spine, but because the canal is relatively wider at the dorsal lumbar level, neurological deficit rarely occurs in a vertical compression injury. Next, you can have an extension injury. So it is commonly seen in the cervical spine. So when there is a motor vehicle accident, the forehead strikes against the windscreen, it forces the neck into hyperextension. And also when you do a shallow water drive, your neck is hyperextended. So basically, imagine it like this. If this is your chin and you're doing a shallow water drive, so you're going like this and the anterior part of the vertebra, it can get chipped off. Okay, so it results in a chip fracture of the anterior rim of a vertebra. So these injuries sometimes may be unstable. And then you can have a flexion distraction injury. It is a recently described spinal injury and it is recognized in Western countries where the use of a seatbelt is compulsory while driving a car. So basically, with the sudden stopping of a car, the upper body is forced outwards by inertia, but the lower part is still tied to the seatbelt. The flexion force thus generated has a distractive component, distraction. So it results in a horizontal fracture extending onto the posterior elements involving a part of the body as well. Okay, so posterior elements, till there it extends, and it also involves the body. So it is termed a chance fracture, and it is an unstable injury. You can also have direct injuries like, bullets shooting into your spine, or a lathi blow directly hitting the spinous process of the cervical vertebrae. So any part of the vertebrae can be smashed by the bullet based on where it goes, but a lathi blow generally causes a fracture of the spinous process only, because that is a prominent part of the spine, right, where you hit. Then you can also have a violent muscle contraction, such as a sudden violent contraction of the psoas. It is very rare, so it results in fractures of the transverse processes of multiple lumbar vertebrae, because the psoas, it kind of inserts onto your transverse processes, right? So that is what happens. So in the presenting complaints, so a patient can have pain in the back. The history is very classic, but it is better to consider any acute pain in the back as a spinal injury unless and until proven otherwise, as a vertebral column injury or spinal injury. Next, you can also have neurological deficits. So the patient is sometimes brought to the hospital with complaints of inability to move the limbs and loss of sensation. Okay, and there's a history of trauma. And then on examination, see, first you have to do a general examination. So a quick general examination should be carried out to evaluate any hypovolemic shock and associated injuries. So you need to resuscitate based on the general examination findings. Then you also proceed on to a neurological examination. See, you carry out the neurological examination before examining the spine per se, because if you do a spinal examination first, then you may aggravate the injuries, and the neurological exam will be more severe. So before, when you do a neurological examination, you can find a baseline level of what the neurological damage is. So you can also find the expected segment of the vertebral damage, and based on that, you can also calculate where the damage can be. So basically, cervical vertebrae, the cord segment, you add 1 to the vertebral level. Upper dorsal, so add 2. Lower dorsal, add 3. Okay, at D10 all the dorsal segments over, at D12 all lumbar segments over, at L1 all sacral segments over, and below L1 it is chorda equina, because the spinal cord ends at L1, so the terminal part, sacral segments at L1, and below L1 it is chorda equina. Alright, then you examine the spine. So in a patient with a suspected spinal injury, utmost care must be observed during examination of the spinal column. So if such care is not observed in an unstable spine, movement at the fracture site may damage the spinal cord. So patient should be tilted by an assistant just enough to permit only the surgeon's hand to be introduced in under the injured segment. So you can feel a prominence of one or more of the spinous processes, tenderness, crepitus, or a hematoma at the site of the injury. So moving on to investigations. See, first you do a plain X-ray. So it is helpful in confirming the diagnosis. If there is a fracture, you can visualize it, assessing the mechanism of the injury, and also assessing the stability of the spine. So basically, you can see if there is any kyphosis or scoliosis. You can see if there is the reduction of height of any vertebra, and you can see any anteroposterior or sideways displacement of the vertebra. You can see a fracture of the vertebral body or the posterior elements. So occasionally plain X-rays may appear normal in the presence of a highly unstable spinal injury. It is commonly seen in whiplash injuries to the cervical spine, where all 3 columns of the spine are first disrupted by hyperflexion. See, your car is going sudden brake, your hyperflexion followed by hyperextension because of inertia. So sometimes a dislocation of the cervical spine may spontaneously be reduced so that there is only minimal finding on an X-ray. So these are some of the radiological features that suggest an unstable injury. So first, if there is wedging of the body in such a way that the anterior height is reduced to more than half of the posterior height. Then if there's a fracture dislocation on an X-ray, okay, if it is getting dislocated, if there is any rotational displacement of the spine, injury to any of the facet joints, the pedicle or the lamina, the posterior column. So an increase in the space between adjacent spinous processes as seen on a lateral X-ray. That is why you need both AP and lateral views. Okay, then you can also do an MRI. So it is the best modality of imaging in an injured spine. So it also shows the anatomy of the cord in addition to showing the better details of the injured bones and soft tissues. And where MRI is not available, you can do a CT. Okay, you can see the damaged structures and also make note of any bony fragment in the spinal canal, vertebral canal. So then here you can see the essential features of different types of spinal injuries. So you can just study the table. Okay. It is a summary of what we have discussed till now essentially. So treatment, again, you have phase 1, 2 and 3. Phase 1 is emergency care at the scene of the accident or in the emergency department. Phase 2 is definitive care in the emergency department or in the ward, and phase 3 is rehabilitation. So phase 1, emergency care at the site of the accident. An acute pain in the back following an injury is to be considered as a spinal injury unless proven otherwise. So all suspected spinal injuries are to be considered unstable unless their stability is confirmed on subsequent investigation. So that is why the patient needs to be given utmost care right at the site of the accident to avoid any movement at the injured segment. So one person should hold the neck in traction by keeping the head pulled. The rest of the body is supported at the shoulder, the pelvis and at the legs. So you have 4 people, one person at the head, mostly the trained person at pulling the neck and holding it in traction, fixing it, one person at the shoulder, one person at the pelvis and another person at the legs. So whenever required, the whole body is to be moved in one piece so that no movement occurs at the spine, because most spinal injuries, they are aggravated on transferring the patient from the site of the accident to the hospital because of improper stabilization. Then in the emergency department, the patient should not be moved from the trolley on which he is received until stability of the spine is confirmed. So in cases of cervical spine injury, use 2 sandbags on either side of the neck. So if this is the neck, then put sandbags on either side of the neck to hold the neck and prevent it from moving here this way and that way. So a quick general examination is to be carried out to detect any other associated injuries to the chest, abdomen, pelvis, etc. And again also do a neurological examination. After doing the neurological examination, examine the spine for any tenderness, crepitus, hematoma, etc. And then investigate with x-rays and all that. Then medical management of a spinal cord injury. Right now people say in some criteria that you do not need to give steroids, but as per this book, so if a patient presents within 8 hours of a spinal injury, IV methylprednisolone is administered as a bolus dose followed by a maintenance dose. Then phase 2, definitive care. So definitive care of a patient with spinal injury depends on the stability of the spine and the presence of a neurological deficit. So if there is a neurological deficit, you don't want it to deteriorate or increase in severity. And then you want to achieve the stability of the spine either by conservative or by operative methods. And also you need to rehabilitate the patient, which is phase 3. Okay. So first, treatment of the cervical spine injuries. They're often associated with head injury. So that is why you focus on the head injury, which is externally visible, instead of thinking about the cervical spine injury underneath. So that is why it is necessary to get an X-ray of the cervical spine in any case of serious head injury. So the aim is to achieve proper alignment of the vertebrae and maintain it in that position till the vertebral column stabilizes. So operative stabilization of the fractured spine has become the treatment of choice as it enhances rehabilitation. So operated. Where the operative facilities are not available, you can go for reduction and stabilization by non-operative methods. So reduction is achieved by skull traction applied through skull calipers. So you have something called the Crutchfield tongs. So you drill the screws into the outer table of the skull, and you put a weight of up to 10 kgs, so applied like this. So you try to maintain it in traction. So you keep taking x-rays and check them every 12 hours. You also keep watch on the patient's neurological status, because it is possible to damage the spinal cord or the medulla by injudicious traction. You don't want to just put traction like that and leave him irresponsibly. So when it is confirmed on x-rays that reduction has been achieved, light traction is continued for 6 weeks. So Crutchfield tongs, apply traction 6 weeks, and then the soft tissues, by this time they get fibrosed, and then after 6 weeks you can do further immobilization just by using a cervical collar or a POP cast. Okay, in about 3 to 4 months, a bony bridge forms between the subluxed vertebrae and the spine stabilizes, and the collar can then be discarded. So operation, this is a treatment method of choice wherever the facilities are available. So it is particularly required for irreducible subluxation because of locking of the articular processes or persistent instability following the conservative treatment. So the operation consists of interbody fusion, which is anterior fusion, or fusion of the spinous processes, and laminae, which is posterior fusion. So you can have a fusion of the anterior part, so the body, and laminae and the spinous processes. Okay, so posteriorly. Internal fixation may be required. So common cervical spine injuries. So you can have a wedge compression fracture of a cervical vertebral body. So it results from a flexion force. Okay, the posterior elements are intact, so the injury is stable. So treatment, you don't reduction is also not required. You can just put some skull traction. Once the pain and spasm subsides, then you can use a cervical collar. So traction followed by cervical collar, POP cast or a brace. Then you do physiotherapy. Burst fracture of the vertebral body. This results from a vertical compression force. The posterior elements are usually intact, but because of the severity of the crushing of the vertebra, the fracture is considered unstable. So if a broken fragment from the body, it gets displaced inside the spinal canal, so again it can result in neurological deficit. So treatment, when there is no neurological deficit, the injury can be treated in just like a wedge compression fracture. So apply traction and then cervical collar. But with neurological involvement, we'll see again. And then subluxation or dislocation of the cervical spine. So flexion rotation force, okay, so flexion rotation force like this, okay, so it is most severe. So it can result in the forward displacement of one vertebra over the other. The displacement may be partial or complete. So sometimes the displacement may be spontaneously reduced, leaving a well-aligned spine but significantly devoid of supporting ligaments. They are unstable injuries again. So again, you need to take AP, lateral, oblique X-ray views also, and MRI also you can do. So treatment, see, because it is highly unstable flexion rotation injury, you have to go for surgical stabilization. It is the treatment of choice. And then uncommon cervical spine injuries. So you can have fracture of the atlas. So a burst fracture of the atlas, where anterior and posterior arches of the atlas are fractured by a vertical force acting through the skull, is a common atlas fracture. It is a Jefferson's fracture. So both anterior and posterior arches of the atlas, vertical compression fracture. So you can have Jefferson's fracture. Then displacement is seldom severe, and the spinal cord, it escapes injury. So treatment consists of traction followed by immobilization in Minerva jacket or halopelvic support. So if it is a Jackson's fracture, use a Minerva jacket, okay, or halopelvic traction. Then atlantoaxial fracture dislocation. So it is more common than pure dislocation. Fracture and dislocation, it is more common than pure dislocation. So pure dislocation is more often associated with a neurological deficit. So displacement is commonly anterior. So treatment consists of skull traction followed by immobilization in the Minerva's jacket. So in due course, the fracture unites and the bridge of C1 and C2, the bone joins it anteriorly and it stabilizes the spine. Then you can have a fracture of the spinous process of D1 vertebra, commonly seen in people who shovel clay like this. So there's no logic, I don't think so. Just remember it as spinous process of D1, common clay shovelers. And then displacement of the intervertebral disc. So a violent flexion compression force can sometimes result in sudden prolapse of the nucleus pulposus of a cervical disc into the vertebral canal, resulting in quadriplegia. An early decompression may give good results. Okay, so treatment of thoracic and lumbar spine injuries. Definitive treatment depends on the presence of neurological deficit and whether it is stable or unstable. Stable, so basically you advise bed rest, give analgesics, and followed by mobilization. So initial mobilization may be done by some external support like a brace, but gradually they're discarded and active rehabilitation is continued till full functions are achieved. Okay, and during bed rest, you try to avoid complications of bed rest because of prolonged immobilization, such as bed sores or any infections. And then unstable injuries, they're either associated with neurological deficit or are likely to develop it during treatment. So you treat it non-operatively with bed rest for 6 weeks, bracing, and then care of the back. Then again, operative intervention in dorsolumbar injuries. So there are clear indications for surgery in these injuries. Okay, so basically if there is a loss of 50% of the vertebral height and a compromise of the spinal canal by 50%. Okay, so see, first you have like this, right? So if the height is compromised by 50%, if the spinal canal is compromised by 50% by any fractured bone or something, and again there exists a 30-degree kyphosis deformity. So there's and if there's a neurological deficit. So operative methods, again you use a pedicle screw with a rod posteriorly and sometimes again support by anterior fixation. See, if there is a spinal injury, first check for neurological deficit. So if the spine is stable, first check. See, if there is an injury, first do neurological examination, then spinal examination. No neurological deficit and the spine is stable, rest for 3 weeks and ash brace for 3 to 4 months. 3 weeks, 3 months. Rest for 3 weeks, ash brace for 3 months. If the spine is not stable Rest for 6 weeks, not 3 weeks. 6 weeks or operative stabilization, and then ash brace for 3 to 4 months. If there is a neurological deficit, then do an MRI. If the canal is not compromised, again bed rest for 6 weeks and ash brace. If the canal is compromised, do decompression and go for internal fixation.